Good afternoon, good evening, friends, colleagues, ladies and gentlemen. I would like to welcome you to the final session of the final and third day of MSAI 2021 Congress. So when we started the Congress on the first day, we started off big, and definitely when we end it, we should end it in a big way. And I think there's nothing more bigger than this session, which is the Apache, the Asia Pacific Allergic Organization, MSAI, the Malaysian Society, Allergy, Immunology, and as well as the Singapore Allergy and Immunology. I'm sorry that I don't pronounce it in the correct way, but I hope you get the idea. And this is our contribution towards the COVID-19 pandemic. And as we all know, COVID-19 is really such a serious issue it affects everyone. And maybe if you don't know it by now, there's a lot of immunological basis towards COVID-19. And this session is actually a prelude to the Apache Allergy Week, which is actually been organized, been led by Professor Dr. Ruby Pawangkar, which is going to start on the 12th of April and ending on the 18th of April. And it's going to, start in a big way with the topic of COVID-19 allergies and vaccine, understanding the facts and the myth. Probably if there is a change, probably will inform us later on. And that one we start off on the 12th of April at about about 1900 the GMT +8 Singapore time. And I've been informed that even the big gun from WHO will be there. And if anybody like to ask questions, like to know more, and I think it's the right session for you to join. And for this session, we have three eminent speakers. Professor Dr. Ruby Pawangkar, who is the president of Apache, Dr. Amir Hamzah, Dr. Abdul Latif, he's the immediate past president of MSAI, and Dr. Cheng Yu Kwan, who's actually a member of the Singapore Allergy and Immunology Society. To start off the session, I would like to introduce to you all the first speaker. Give me great honor to say that even though she hails and she's now actually in Tokyo, Japan, but she's not a foreigner to us. She's not foreign to Malaysia. She's a regular in our meeting, a great friend of MSAI. She actually going to share with us her experience on COVID-19, in terms of the relation to the allergy, asthma, immunology, as well as the impact of the air pollution in terms of the overall situation. Professor Dr. Ruby Pawangkar is currently the president of Apache, is a professor of allergy at the Department of Pediatrics at Nippon Medical School, Tokyo. She actually is a member of various international organizations, mainly the Allergy Society of the international body. She has been awarded several distinguished awards, and one of them from the President of India. And I think research and publications are actually in her blood. She has been publishing widely, doing a lot of research, even at the cellular and molecular mechanism. And because of her contribution, she actually been recognized and actually has been appointed as editor of numerous international and also prestigious journal in the world. And also she's actually one of the panelists at the United Nations, especially environment and health, as well as the visiting professors to several of the prestigious universities. Professor Dr. Ravi Pawangkar, the floor is all yours.
Thank you very much, Professor Baha, for your kind introduction. I would like to give warm greetings from Apache, from myself and the board of directors of Apache, to the Malaysian Society of Allergy and Immunology, and also, of course, to the Singapore Society of Allergy and Clinical Immunology. My relationship, as Prof. Baha said, with the MSAI has been right from its inception, and it's always been a pleasure and honor to work together. We also had a wonderful experience doing the Apache Congress in 2016 in Malaysia, which was really an excellent scientific as well as organizational and culturally beautiful Congress. So my great thanks to you, Prof. Baha. My deepest gratitude to Prof. Amir, who is also our board second vice president of Apache, and also Professor Kent Wu, who is the president-elect, and to all members of MSAI. So I would start by saying that, as Prof. Baha said, our very important point is we are starting this as a prelude to the Allergy Week next week, Apache Allergy Week, which is focusing on COVID-19. So this session will cover three aspects, as he has already explained, and I'm going to talk about COVID-19, allergy, asthma, some of the immunological aspects and mechanisms, and the impact of air pollution. So if you look at this slide, you can see that there are three different viruses mentioned here: the SARS-CoV-1, the MERS, and the SARS-CoV-2. The SARS-CoV-2 is actually the one that causes COVID-19. Now, in SARS-CoV-1 and SARS-CoV-2 and MERS, all of them are from animal to animal and then to human. The common and most important point that I'd like to highlight in this very busy slide is the fact that between SARS-CoV-1 and SARS-CoV-2, they share the same receptor in the host cell, that is the ACE2 receptor. So that particular aspect is common to both SARS-CoV-1 and SARS-CoV-2, although SARS-CoV-1 was limited as compared to SARS-CoV-2, which today is a pandemic affecting over 200 countries in the world. When you look at this sequence of events, you can see the whole sequence of how the first case was reported in December end in Wuhan, and then, of course, you can see the virus related, it was sequenced. Then, of course, it was identified that that's the origin of this particular infection. And then, of course, Wuhan went into a lockdown with the large number of cases that were occurring there. Then it spread to other parts of the world, and the global World Health Organization announced it as a pandemic, as a global health emergency. And then, of course, it was named that the SARS-CoV-2 infection is called COVID-19. And from then on, we have had a series of countries that have had massive numbers of patients with COVID, starting from Italy, moving to US and UK, India, Brazil, and of course, all over the world. The important part I'd like to highlight in this slide are the different proteins and their active. But the most important I'd like to highlight is about, am I not able to go back? Can I not go back? Oh, it's okay. The important part is there are multiple proteins, and each of the proteins do different functions. Like you have the spike protein, you have the membrane protein, you have the envelope protein, you have the nuclear protein, and so on. And each of them have different activities. In fact, the most important is the spike protein, because the spike protein is the one that actually attaches itself to the host cell. And it is against the spike protein that many of these vaccines are being developed or have been developed that we have today and are being rolled out across the world. Then you have the membrane protein and the nuclear protein and the envelope protein that have different responses, like dampening the interferon gamma response, causing cellular damage, causing apoptosis, and so on, and of course viral replication. Now, this is actually the mechanism that you can see how the SARS-CoV-2 virus actually attaches itself to the host cell, and this is through the ACE2 receptor. Now, the ACE2 receptor is mainly seen, you can see it attaches itself to type 2 pneumocytes and also vascular endothelium. And once it attaches itself there and has its different immunological activities that happen within the cell, it then moves into the bloodstream and affects other parts of the body. Now, this is the overall mechanism that you can see out here, that once a SARS-CoV-2 enters the airways, it attaches itself to the pneumocytes, and then from the pneumocytes, it goes into the bloodstream. And via this, it actually causes a dampening of the Th1 response. It dampens the interferon gamma response, and it actually causes an infiltration of a number of immunological cells like macrophages and monocytes and neutrophils into the tissue. And then after that, there is also a Th1, Th17 response leading to the antibody production. Now, when you look at the clinical features of what happens in COVID-19, you can find that there's symptoms like fever, cough, fatigue, gastrointestinal symptoms, and some respiratory symptoms and cough. But the most important thing is, in the more severe cases, you will find that they have a rapid respiratory rate reduction in their saturation SpO2 at room air, and their X-ray findings, chest CT scan shows ground glass opacities. When you look at the comorbidities, actually, that is shown in this study, you can see hypertension and diabetes being two of the main comorbidities seen, although obesity is also there. And the less common ones are COPD and, of course, urticaria and so on. But interestingly, atopic diseases like asthma, allergic rhinitis, and atopic dermatitis or food allergy were not found to be as a major comorbidity. And this is very unusual because usually in viral infections, we find asthmatics are more prone or susceptible to viral infections. Now, when you look at the different symptoms, we know that this is not limited to just respiratory symptoms. There are multiple organs that are affected. And as you can see here very clearly, there are symptoms affecting the gastrointestinal tract, symptoms affecting the cardiovascular system, symptoms affecting even the neurological system. And then, of course, in children, even a Kawasaki syndrome kind of disease can be seen, especially this was reported in the United States. So in addition to the respiratory symptoms, there are many of the multi-organ findings that you can see in SARS-CoV-2 or COVID infection, that is COVID-19. And the CT scan very clearly shows very clear ground glass opacities, and there is more lymphopenia that you can see. Now, in this study in China, where they looked at about 298 confirmed cases, they looked at what are the risk factors that are associated with the severity of disease, and it's summarized in this slide here. Now, if you look at this slide, you can see very clearly that the risk factors comprise of multiple different things, like, for example, age. The older you are, the more likely. The presence of different comorbidities, the high CRP, high ESR, and high interleukin-6. So these different parameters were associated with increased risk for severity of the disease. Now, when you come to actually the disease progression and you divide it into, simplify it into three different stages, stage 1, stage 2, and stage 3. The stage 1 is the early infectious stage where there is actually viral response, And then the second stage starts with the beginning of the host inflammatory response, which is the pulmonary phase, and then the more severe form, which is the hyperinflammatory phase, what we call as the cytokine syndrome. And then you can see here very clearly that the symptoms associated also vary, with milder symptoms occurring in the stage 1 and more severe respiratory and distress of ARDS occurring in stage 3. Similarly, you can see that the different molecules that you can actually see in the different stages, that in the early stage, you can find higher levels of certain lymphopenia and so on, whereas further down in the more severe cases, you'll find high levels of D-dimer, ferritin, and procalcitonin, and so on. When you look at some of the treatments that have been given over time, you can see that there are some antivirals, as well as you can see there are also drugs that reduce immunosuppression, like corticosteroids, or anti-cytokines like anti-IL-6. Now, when you're looking at the way the disease progressed from mild to moderate, or whether it is actually more severe, this is what exactly happens. When there's actually the inflammation occurring, and then there is a regulated inflammation, and because there's a regulated inflammation, so then there is a dampening of the inflammation, and the viral replication is reduced, and there is a viral clearance. And this results in the resolution of the disease. On the other hand, in the more severe disease, there is more viral replication, and there is, of course, more viral activity. There is increased cytokines that are released, called the cytokine syndrome, which includes interleukin 1, interleukin 6, TNF-alpha, and so on. And all these together causes tissue damp, upregulation, virus PAMPs, upregulation, and ARDS, and more severe disease, and multi-organ failure and death. Now, when we talk about this the cytokine syndrome, one thing that comes to our mind is the fact that this is something like the MAS, or macrophage activating syndrome. Now, in this, you can see that the cytokines play a role both in COVID-19 induced pneumonia and in macrophage activating syndrome-like disease. So you can see multiple different cytokines playing an important role, and prominent among them are interleukin 6 and interleukin 1 activation. The other important thing is that this mass-like inflammation is seen in COVID-19 is mainly confined to the lung parenchyma and the alveolar tissue. And what actually happens here is that there is a upregulation of all these different cytokines that I will show you in a different slide that results in this huge amount of inflammatory reactions in the different tissues, starting from the cardiac tissue to the neurological system, the brain, and also the skin, and so on. So this is actually to show you the different cytokines that are seen in those who are in the ICU, COVID-19 patients admitted in ICU, so the more severe cases, then COVID-19 cases, non-ICU cases, and normals. And you can see across the different cytokines, there is increased IL-2, IL-7, IL-10, GCSF, IP10, MCP1, MIP1 alpha, and TNF-alpha, and all these are much higher in those cases that are in the ICU, indicating such a massive cytokine storm that's actually causing the severity of disease affecting the different organs. So when you come to the biomarkers of the cytokine storm, because this is also very important when it comes to treatment, you can see that it can be something like just the blood count, but also things like LDH and ferritin and IL-25 and IL-2 and interferon gamma, D-dimer. These are different biomarkers for the cytokine storm. And we are still understanding many aspects of this disease. because this disease is also presenting in different forms in different parts of the world, and it's also changing its forms as we see that the new variants are emerging. And therefore, it is also important to study further and understand what are the key factors that affect the particular type of COVID that's occurring in your country and in your region. Now, we have had several therapeutic modalities that are antiviral or anti-inflammatory. I already mentioned some of them. And this is just a slide that shows the way it acts, how anti-IL-1 acts, how anti-IL-6 or tocilizumab acts, and of course, remdesivir. So many of these treatments are already being used clinically for more severe cases. And also some of them are used in the early stage of the disease, like to prevent viral replication, like remdesivir. So at different stages. So at one point of time, when we understand more of the disease, this will be like what we think in asthma or other diseases, where you will have a phenotyping that there will be also probably a stage when a particular treatment is more effective at a certain stage of the disease, but may not be effective at the other stage of disease. So this is very, very important aspect. Now, this particular slide just summarizes, and it's there on the Apache website. So for those of you who would like to even have more information, and we will be updating this on a regular basis, this shows the rollout of the vaccines in the Asia-Pacific region. And this is very important. While I must say that Asia-Pacific in some way is in better situation than we look at, especially this far east of Asia and Australia, Singapore, Taiwan, have had better results as compared to, of course, India and Malaysia, Philippines, where the cases are much more. But still, as compared to the United States or UK or Italy or Brazil, we are far better. But again, this raises a question: is this ethnicity? Is this something to do with our diet? What is it that makes us respond differently? Is something that I think only the future can tell. But this slide shows you the different vaccines we have in our region, which includes vaccines like from the Pfizer, Moderna, AstraZeneca, then Sinopharm, Sinovac. So these are the different countries have different vaccines, and many of them also have multiple vaccines that are available and administered to the people. Very important for us as allergists is because there are cases of course, adverse events. That is a known thing. All vaccines and, of course, many drugs have adverse events. Now, we highlight this more because this is a vaccine that has been developed in such a short time. People are therefore more apprehensive. And, of course, when there is a single case or 10 cases of anaphylaxis, it becomes very much highlighted. Whereas most of the vaccines historically do have side effects. Now, the number of cases of anaphylaxis are numerically small compared to the number of people who have been vaccinated. And so also are the number of cases which have thrombosis in case of the AstraZeneca vaccine. That doesn't mean that we should not find out what one can do to actually avoid those things. That is what we call as risk stratification. And that is an important thing that authorities, regulators, and the World Health Organization and organizations like us are looking into as how we can risk stratify this and how we can actually safely implement vaccination to our public, because vaccination is very important in order to get out of this COVID-19 and to achieve herd immunity. So just to summarize what's on this slide is we just compared CDC, UK and our Apache recommendations, which are almost all the same, again telling us that which are the cases where we would avoid totally the utilization of the vaccine. So for example, a severe anaphylactic reaction to the first dose, or for example, to another mRNA vaccine, say, for example, that Pfizer, and then you try to use Moderna. Of course, one wouldn't suggest that. And of course, there's not evidence yet where using another vaccine would help. And that's being studied now by the different pharmaceutical companies and the scientists as to whether that can be used. So for now, these recommendations are very crucial. But how do we safe implementation? The main issue is that in most of these, the adverse reaction, at least anaphylaxis, occurs because of PEG or polysorbate, which is an excipient that is present in it. So in the United States, they even have skin testing for PEG to actually identify whether a person reacts to that in case there is a history of anaphylaxis. But of course, this is not commonly available everywhere, so there are limitations. But at the same time, what is most important is we need to be careful that patients with food allergies, patients with asthma, patients with allergic rhinitis, patients with atopic eczema can receive the vaccine. There is no inhibition or there is no restriction or no risk for them to have the vaccine. Of course, there are recommendations based on the countries of pre-medicating. Some countries recommend use of H1 and H2 antihistamine plus a montelukast half an hour before. Others don't make those recommendations, but that again depends from country to country. Now, just a little bit about COVID-19 asthma and allergies. And as I told you earlier, that the study had shown in China, in early stages, had shown that there's not so much of comorbidity with asthma. Let us look at what happened in Italy. And if you look at in Italy here, you can see all those places where there are huge numbers of COVID during their first phase of the surge. The number of cases that had asthma were very few. So asthma was really not found to be a comorbidity as compared to diabetes or hypertension. Now, what could be the reason? There are, of course, this is again just a hypothesis, and it's a very interesting area to study. But what is interesting is that in the TS2 type of environment, like in allergic disease, you have a downregulation of the ACE2 receptor and the RSS2, which are actually the important receptors to which the SARS-CoV virus actually binds. So if there is a downregulation, there'll be less number of viruses that can bind to it, and therefore the less chance to have disease. In addition, of course, MBL and SPD, these are surfactant proteins that compete with the SARS-CoV-2 to bind with the ACE2 receptor. And therefore, again, that is increased in allergic diseases and therefore, again, dampening. Then, of course, you have other factors like increased TH2 type of cytokines, and of course, the treatments like inhaled corticosteroids that actually downregulate or dampen the effect of this viral replication and viral entry. And this is just the other way around. In case of SARS-CoV-2, you can find increased inflammatory cells, increased CD8 positive, increased lymphopenia, increased eosinophenia, and you get a very aberrant antiviral effect. And of course, there is in allergy, you'll find more of a trained immunity. So in this kind of a phenomenon is one of the hypotheses why asthma may not be a comorbidity. The other thing is looking at IL-13 and ACE2 receptor. You can see the nasal epithelium and in the bronchial epithelium. Where there is upregulated IL-13, there is less ACE2 receptor expression, lower, both in nasal and bronchial epithelium. Also, when you do the allergen challenge, again, you can see that after allergen challenge, there's a downregulation of ACE2 receptor both in the nose and in the lower airways, again showing that a TH2 type of environment and IL-13 could actually downregulate ACE2 receptor and therefore the binding of SARS-CoV-2. So we need to understand that there is a modulation of the ACE2 receptor expression, and how can we evaluate the role of this TH2 type cytokines in the immunological pathogenesis of COVID-19. So the key points here, of course, as I mentioned earlier, is severe asthma or asthma is not a risk for SARS-CoV-2. There are potential different reasons. One is, of course, the fact of this ACE2 receptor and DMPRSS2 receptor downregulation. And the other, of course, could be other additive factors that patients with asthma are more adherent during this because they are worried, they're anxious, and they want to stay adherent to their treatment. Whereas in a normal situation, they may be not so compliant with the treatment. And also the fact that ICS, inhaled corticosteroids, might also prevent or mitigate the development of SARS-CoV-2 infection. What is crucial here for us to convey to our patients as allergists is to ensure that the patients are taking their prescribed medications properly, especially inhaled corticosteroids, regularly and keeping their asthma under control, that they have a written asthma action plan, that they stay in contact, whether it is due to by direct consult, as can be possible in some countries, or through telehealth. Either ways, to stay in touch with the treating physician, but to be compliant with the medication. And this is absolutely crucial. And the other important thing is that we say avoid nebulizers, because that can actually cause more spread or dissemination of the virus while using a nebulizer. So metered MDIs are what are recommended with a spacer for patients rather than using a nebulizer. What about allergic rhinitis? Again, allergic rhinitis, we don't have so much evidence about COVID-19 allergic rhinitis, but what we can just say is that don't stop your intranasal steroids. You need to take your intranasal steroids. You need to take your allergic rhinitis medications, whether it's antihistamines or intranasal steroids. And especially people fear that, oh, maybe you shouldn't take an intranasal steroid, but you should continue. There is no clear evidence against it, and controlling the allergic rhinitis, like asthma, would be key in this period of the pandemic. What about immunotherapy? Now, I'm not going to talk all about this because it would take another hour if I had to talk about it, but just to say that immunotherapy also should be continued. Now, if it's injectable immunotherapy, you have to consult with your doctor, and your doctor will give you the right advice as to what should be done, because whether you can visit the doctor, how it should be done, whether you switch to the slit, these kind of guidance has to be very, very directed by your consulting physician, and by the consulting physician, as well as by the regulatory aspects that is there in their country. For us in Japan, because patients can actually still visit the hospitals, it's not an issue at all. And then in the case of sublingual immunotherapy, of course, they can continue to take it because it's taken at home, and there is no issue to continue the treatment, and it's not contraindicated. And finally, I'd just like to say a few words about COVID and air pollution. Yes, we all know that when there is lockdown, the sky is clear and the pollution goes off. I mean, I've not seen better, clearer skies, photographs of better, clearer skies in Delhi, for example, during the lockdown, because there's no vehicles, there's no pollution. And so that really helps in some way. But on the other hand, some studies have shown that air pollution is actually an aggravating factor for COVID-19. And this is actually the graphical expression of the pollution, the highly polluted areas, and the presence of COVID-19 during the surge. But what I'd like to summarize here to make it easier is that there is a tripling of infection rate for an average PM 2.5 rise from 10 to 22 microgram per cubic meter. So PM 2.5 plays a crucial role in actually enhancing the possibility of infection. And not just infection also, but also the case fatality ratio, that is death to infection ratio, is also strongly dependent on PM 2.5. The other important thing is, besides that, PM 2.5 also causes the ACE2 receptor overexpression. And this again would aggregate, because it would allow more virus binding to the ACE2 receptor. And the high atmospheric NO2 can provide a second hit by actually causing form of SARS-CoV-2 in the ACE2 depleted lungs. So first you have a dampening of the increase of the ACE2 receptor. Once the ACE2 receptor is already bound by the SARS-CoV-2 virus, and there is a depletion of the ACE2 receptor open sites on the pneumocyte, then the NO2 may provide a second hit, causing the worsening of disease. Now, this is actually some of the summary. It's a little bit old. It's maybe a few months old, but it just summarizes that even this aspect of the air pollution, because we have not done a study that is a very planned study and looking at very well-designed study looking at the impact of air pollution, because COVID itself is changing so much in its pattern and its expression. But so there are some studies that clearly show that air pollution actually aggravates it, whereas others don't have sufficient evidence. They just show that there is a lack of evidence. So still, it's a matter of discussion. And finally, I'd like to just introduce you to our board. Our board is on the top. You can see here, Professor Amir is our second vice president in this picture. He is there. Apache is very much active in doing many initiatives, like we have 22 committees, disease-specific committees. We are bringing out many publications, guidelines, consensus documents, and surveys, and we are very much looking forward to greater participation and greater collaborations in our various scientific activities, our e-learnings, and we also look at contribution from MSAI leadership and younger generation to become part of Apache. And then, of course, don't miss this. As Prof. Baha said in the beginning, this is the link to the live webinar. It's been circulated to all. If you have not received it, you can get it from Prof. Baha, or Prof. Amir, or Prof. Wu. They have received it. We have got an excellent lineup of faculty, including a parliamentarian from Australia, but most importantly, two leadership from the World Health Organization, Maria Van Kerkhove and Dr. Soumya Swaminathan. Maria is the lead of the COVID team in WHO, and Dr. Soumya Swaminathan is the chief scientific officer and a classmate of mine. And so you have the top people. Dr. Mariana Castas is from Harvard, and she leads the initiative for how to do safe implementation of vaccine. Bernard and Amir and Marisa and all the Prof. Wang and all the people out here are going to be available to you. So please do participate in this 1.5 hour live webinar at 7 p.m. on Monday. And it's free. You just have to register online. And finally, I'd like to invite you either in person or virtually to the Taiwan meeting this October and to the Philippine meeting next October. The Philippine, of course, we believe will definitely be live. The Taiwan may be a hybrid, but we hope that we will be able to actually control this pandemic and meet face to face. Thank you very much for your kind attention. Terima kasih.
It's a very comprehensive coverage of COVID-19 and all those pertinent and relevant conditions associated with the pathophysiology, diagnosis, and management of COVID-19. I'm sure we have certain things that we'd like to discuss afterwards. I have some housekeeping announcement before I introduce the next speaker. I'm sorry I was too excited earlier and I forgot to highlight that since this is the last day, this is the only opportunity for our participants to download their certificate of attendance for this meeting, as well as to obtain their CPD points of 20 for those Malaysian physicians. It's going to be closed after the meeting, so I hope you will do it as soon as possible. Since everything is free, we don't charge anything for the download of the certificate and also the CPD point. But for those who want to, for the secretariat to send them the physical certificate, there is a certain fee that we're going to charge. In a way, our effort to discourage the use of paper, because nowadays we have to be really environmental friendly. And I hope that those who don't want to download themselves, they want us to send the certificate to them. I hope they also don't mind to pay a certain fee for us to do that for them. Now, ladies and gentlemen, I like to bring your attention to the next topic and also the next speaker. The next topic is the primary immunodeficiencies and COVID-19. Quite broad topic from diagnostic to vaccine. And the speaker is none other than my good friend, Dr. Amin Hamzah, Datuk Abdul Latif, who is also the immediate past president of Malaysian Society Allergy and Immunology. And also Professor Dr. B. Pabanka also has already highlighted that he is one of the ESCO members, the second vice president of Apache. he received his training from both Malaysia as well as United Kingdom in clinical immunology as well as allergy. He has been practicing since as a certified allergist and immunologist, but maybe some don't know that, not aware that he's also a pediatrician. He has been practicing since 2003 and 2005 onwards, and also been practicing as well in United Kingdom. He's actually now the consultant, the senior consultant of in the Pantai Hospital. He has actually been treating a lot of patients related to allergy as well as immunology, and he has actually been, widely published. He has published widely, and also one of the key members in the consensus guideline. Ladies and gentlemen, I'd like to welcome Dr. Amir Hamzah to give us a lecture on the next topic. And now to you, Dr. Amir.
Good afternoon. Assalamualaikum. Salam sejahtera. Today I'll be talking about primary immunodeficiencies and COVID-19 from diagnostics to vaccines. So what I will cover in the next 30 minutes or so will be on primary immunodeficiencies itself, of course, PID, or as it is more widely known now as inborn errors of immunity, IEI, and to look at the whether severe COVID-19 is actually an IEI in its own right, and to look at the COVID infections in IEI in general. Look at the MSAI MSAI joint statement for management of PID patients in Malaysia in particular. But of course, this will be relevant to the other parts of the region. And also to look at the COVID-19 vaccines in relation to IEI. So collectively, we say that IEI is not rare. Although individually, it might range from 1 in 150 prevalence to maybe even 1 in a million, but collectively, it is recurring in about a prevalence of 1 in 1,200. So it is not rare. And from here, you can see that since about 1983, the IUIS, or the International Union of Immunological Societies, started to have their own committee to look at the classification of the IEI. And you can see that the rate of discovery of novel inborn errors of immunity, IEI, from 1983 to 2019, the number of genetic defects underlying monogenic immune disorders, as reported by the IUIS / WHO committee, still there in the background, is indicated each year. And you will see that the number of pathogenic gene variants listed in each table by the IUIS committee, and the numbers in each column correspond to the number of genes reported in 2017 in blue, and then the new ones are in red for the 2019 classification, which is the latest classification. As we know, the classification of IEI, the latest 2019 IUIS report, showed a new group, group number 9, which is the bone marrow failure. But otherwise, the rest are as previously stated in 2017. And it was from 2017 that the term IEI came about as well. Now, if we are going to diagnose and consider IEI, the key question that confronts most clinicians and diagnosticians is how to facilitate a timely and accurate diagnosis so that we reduce or eliminate the diagnostic odyssey most patients with this disease typically face. Now, here is a schema of how one could evaluate the IEI. and a three-prong approach to these diseases. So of course, the absolute necessity for a thorough clinical evaluation, family history, and then coupled with a systematic and tiered approach to immunological and functional assessment, along with genomic or genetic analysis through next generation approaches, and of course, which in all ties back to the first two aspect. Okay, so we would like to aim for an accurate diagnosis of IEI, and I think because we deal with allergies routinely, so along the line we will of course uh, consider whether those with atopy may have actually IEI in the background. And you would need to consider this because one of them could be an SCID or an Omen syndrome in a child who has got eczema. And as we all know, SCID is a pediatric emergency and requires stem cell transplant. So from here, we can also evaluate looking at the high IgE and see whether there's hyper IgE syndrome or the Wiskott-Aldrich or Wiskott-Aldrich syndrome-like condition, and so on. And hence, as allergies as well, or anyone who deals with allergy will need to consider that there would be potentially an IEI in the background. Now, although the vast majority of II are single gene defects, with the advent of advanced genomic methodologies, the concept of digenic inheritance has now entered the field. The collective consciousness of the field now talks about this digenic inheritance rather than monogenic. And digenic IIs are likely to have an altered phenotype due to the phenomenon of epistasis, which essentially involves synergistic interaction of two or more genetic loci in a non-linear manner. So here's an example of a digenic immunodeficiency due to epistasis between the TCF3 and the TNF receptor SF13B genes. And in this case, you can see the proband has heterozygous variants in both genes, whereas other members had variants in one of these genes, and they, one may have a heterozygous DCF variant. So the epistatic changes can substantially modulate the phenotype, whether this could be into one another gene and creating an entirely new phenotype, or in some cases, one gene may exert a more dominant effect on the phenotype than the second gene, whether this is in the same biochemical or immune differentiation pathway. And in other cases, the phenotype may reflect the effect of variants in both genes. So hence, this is the multitude of factors, the Pollock concept, which influences the phenotype in IEIs. Hence, compels us to look and consider new paradigms for the diagnosis and management of these diseases. So an optimal diagnostic paradigm for any patient should use this trinitarian model or this three-prong attack of clinical evaluation, immunological phenotype, and genetic assessment. So the relevance of each component, clinical, genetic, and immune function, and phenotyping in total should be the approach to inborn errors of immunity. And of course, we talk a lot about newborn screening for SCID, or in children and adults through a combination of clinical phenotype, family history and diagnostic evaluation, and again, leading up to the immunological, functional, and genomic testing. So this would be the approach to IEI in general. whilst the actual committee probably will be meeting, the IUIS meeting in this year, but they have already met last year itself, because there were just too many new inborn error of immunity um, genes um, found, and they felt that waiting for another year, that means 2022, to give the updates was just too long. So you can see here, I'm not going to go into this, but you can see in quite a few of the tables, the severe combined immunodeficiency, predominantly antibody deficiencies. There are many other new genes that are being found. Now, some of you would realize that several of these genes are already included in the previous IUIS updates, namely your IL-6ST, the STAT2, the CEB, and RIPK1. But they are listed here because the variant identified is pathogenic via a distinct mechanism and or a different mode of inheritance. That is autosomal recessive versus autosomal dominant for ILST1 or RIPK1, and so on and so forth. So then, of course, they will also discover a gain of function variants reported for the CBPE, and this appear to represent the first described germline neomorphic mutation in IEI, where the variant allele has completely novel function not seen for the wild type gene. So I think the discoveries over the past 12 months in the field of IEI have further identified non-redundant functions of the key genes in human immune cell development, host defense, and immune regulation. So this snapshot of the genetic discoveries underpinning human immune disorders further highlights the critical contributions of IEI to our broader understanding of basic translational and clinical immunology. So now, what about severe COVID-19? Is it an IEI? Right. So if you look at the group that was led by Jean-Laurent Casanova, they wanted to look into this because they've been doing a lot of their own looking into serious infections, and they will find that there has been a gene defect. So they established the COVID human genetic effort to test their general hypothesis that life-threatening COVID-19 in some or most patients may be caused by a monogenic IEI to SARS-CoV-2 with incomplete or complete penetrance. So they sequenced the exome of or genome of 659 patients of various ancestries with life-threatening COVID-19 pneumonia, and 534 subjects with asymptomatic or benign infection. So they then tested the hypothesis, thinking that the inborn errors of toll-like receptor 3, right, and the interferon regulatory factor 7, as well as the interferon immunity, basically dependent immunity, could underlie the life-threatening influenza pneumonia, could also be underlying the life-threatening COVID-19 pneumonia. So they've already discovered these problems for severe influenza pneumonia. So they put and tested their hypothesis towards a severe COVID-19 pneumonia. So they considered that 3 loci and as mutated in patients with life-threatening influenza. Okay, so now put it together and see whether it's the same thing will be found in those with severe COVID-19 pneumonia. So from here, they tested experimental tests for about 118 rare non-synonymous variants of these 13 genes. There were 10 other mutated loci. They were looking up for others viral illnesses. Okay, so in total they had 13, not just the 3 that I mentioned, and found that patients with critical disease were identified in 23 patients. So that means 3.5%, okay, were carrying 24 deleterious variants of the 8 genes. So you can see from here that they concluded that at least 3.5% of patients with life-threatening COVID-19 pneumonia had known deficiencies of the ERF7, of the interferon AR1, and also autosomal dominant TL3 and the rest. So meaning that this discovery reveals essential roles for both the double-stranded RNA sensor TLR3 and the type 1 interferon cell intrinsic immunity in the control of SARS-CoV-2 infection. So the type 1 interferon administration may be of therapeutic benefit in selected patients, at least in the course of the SARS-CoV-2 infection. So in the other accompanying study in the same group, strikingly, they found that about 10% of patients with severe COVID-19 have high levels of neutralizing autoantibodies against type 1 interferons in their serum. Now, the impact of these autoantibodies were evidenced by the inability to detect interferon in serum from these patients and their capacity to prevent antiviral immune response in vitro. So now we also realize there could be deficiency. Now they can also be the autoantibodies to the type 1 interferons, and hence causing the underlying life-threatening COVID-19 pneumonia. So I think when you look into at least the phenocopies of IEI, then we would suggest that COVID-19, severe COVID-19, is a phenocopy of an IEI. So I think this is why having the knowledge and building up clinical immunology in any country is important to advance and to find new conditions, understand diseases, and have new treatments from there. So now we just look in general on the COVID-19 infections in IEI. So there are studies to show how many of these patients in IEI, with IEI, had COVID-19 infections. So not going to go too much into this. So this is basically the background to show the immune response to the SARS-CoV-2 and the mechanisms of immunopathological changes in the COVID-19. And I think this is a well known slide as well, looking at the specific antibody response to SARS-CoV-2, and we have the incubation period, the disease per se, and of course the convalescence. And here's the question really, right? How long does immunity last? So this is not going to be discussed here today. That's another big topic of discussion in its own right. But if you look at the pathogenesis of the severe COVID-19 that I mentioned from before, so this was obviously taken up as the sort of way back in 2020 to look at all the possibilities of the different pathophysiology. But now, as you can see, I have already alluded to the fact that in some of the severe COVID-19 infections, there could be a form of IEI. So if you look into the study, because of the uncertainty of about the impact of COVID-19 in individuals with rare IEI, a retrospective study was done, and this study was distributed globally to scientific, medical, patient societies involved in the care and advocacy for patients with IEI. So the This is coming from the group led by ISID, and they found that there were 94 patients from the survey that had COVID-19 infection. Their median age was 25 to 34 years. 56% suffered from primary antibody deficiency. 9.6, about 10%, had um, autoimmune dysregulation syndrome. 6.4% phagocytic defect, right? Okay. And 7 here, that is 7.4% of the autoinflammatory disorders. And then we have 14 or 15% with combined immunodeficiency. 3% had innate immune defect, and 2% had bone marrow failure. So out of this 94, 10 were asymptomatic, 25 were treated as outpatients, okay, and 28 required admission without intensive care or ventilation, and 13 required ventilation or oxygen administration. And there were 9 patients who unfortunately died, 7 adults and 2 children. So this is the, shall we say, the European data, I mean, more global data. And if you look into the study cohort from UK, so they did the same thing, and they documented individuals with PID or symptomatic secondary immunodeficiency following COVID-19 in the UK. And what they did was to establish a registry of cases and to collate the nationwide outcome of COVID-19 in individuals with PID or symptomatic secondary immunodeficiency. So you can see here the number of cases of PID and secondary immunodeficiency, and of course, when you look at this, they found all in by July 1st, 2020, a total of 100 patients, 60 with PID, 7 with other inborn errors of immunity, and including autoinflammatory diseases and C1 inhibitor deficiency. So when you look at into all that, so the other autoinflammatory diseases, this is just how they have classified the PIDs, okay? So it might look a little bit confusing when you look at the numbers, PIDs, and then other autoinflammatory disease, and other inborn errors of immunity. I suppose it's just a more detailed way of classifying. So, but what they have noted is that the individuals with secondary immunodeficiency had worse outcomes than those with primary immunodeficiency, right? So that's the one of the take-home message they have. And if you look at the and this is of course because of the comorbidities, basically. And if they then look into the prevalence of the common comorbidities in patients with PID hospitalized with COVID-19, then you can see here those. Then they compared it with the general population. So those in the general population, so that would be the blue bars, okay, and then the red bars are those with COVID-19, PID patients with COVID-19. So the data represents the percentage of individuals within each age bracket with comorbidity, and the binomial CIs were calculated by Wilson's method. So from here, you could see they look into the cardiovascular disease, chronic lung disease, asthma, chronic kidney disease, chronic liver disease, diabetes mellitus, and other rheumatological conditions. So I think basically what they are saying here is that whilst it's interesting to note the relationship between comorbidities, their severity and outcomes um, with patients who had the COVID-19 with immunodeficiency, all this appears to be very complex, okay? And so we need further larger studies to explore the relationships between underlying immunology defects and the severity immune deficiency associated comorbidities with respect to COVID-19 outcomes. So there are just too many compoundings to really say, and I suppose answer that simple question. Is the risk of those who IEI going to be higher to get the COVID-19 infection? So there's something to look forward to, because this condition is just not going to, and currently doesn't seem to be wanting to go away, and the pandemic continues. So looking at another cohort, and this is from Iran. This is from the late um, Asghar Muhammadi's group. The late Asghar Muhammadi unfortunately succumbed to COVID-19, and this was very sad news for the community. But nonetheless, he managed to get this study going, and just to show, they just found out of the 9 main groups, only 6 categories of PID or IEI were found to have COVID-19 infections. Now, whether the fact that they didn't find any in the innate or complement deficiencies, not too sure the significance of that. That was the conclusion. So you can see there are cases around the world being reporting COVID-19 infections in IEI. Just that the question is whether would there have been an increased risk in the first place, but as I've already alluded, it's not that clear cut. And on top of that, it could be also a phenocopy for those with a severe COVID-19 infection as a IEI. So now I go next to the joint statement that we came up, MSAI, together with the Malaysian Patient Organization for primary immunodeficiencies. So the MSAI MyPOPI joint statement on the current epidemics of new coronavirus SARS-CoV-2, COVID-19 for the management of PID patients was produced and by a template from the IPOP and catered for our local context. And this statement was issued way back after after our MCO here, our lockdown or circuit breaker to others around the world. We call it the Movement Control Order, or MCO, that occurred on the 18th of March 2020, and we came out with this joint statement. So I think at that point, we were saying that there was no substantial data pointing to whether PID patients actually at higher risk, and I think we still are not sure of that, but we have to just assume as such given their conditions. And the asymptomatic, for those who are asymptomatic but potentially could have a severe infection, should really be admitted rather than taken care as an outpatient. And of course, we will recommend an RT-PCR test and should be available quickly within 4 hours or so. And of course, this would be the number of tests would be as per national guideline, the MOH, but may require additional frequency of testing in patients with IEI. And just to note, obviously, patients with humoral deficiencies will not produce antibodies towards the COVID-19. So those so-called rapid test kits detecting IgM and IgG should not be utilized in these subsets of patients. So we look at the PID patients with lung and heart complications or solid organ transplant PID patient recipients, and those who have undergoing treatment for cancer, and as well for those patients with under immunosuppressants should remain on their specific therapy until recommended otherwise by their PID expert physician. So that's the recommendation. And those who are receiving the plasma-derived medicinal products, such as immunoglobulins, these are safe, and it should protect the patients from many other infections, and that's so important. And the patients should be reminded that they should not change or alter the immunoglobulin replacement therapy dose without consulting the clinical immunologist. Um, However, for those on IRT, there's no evidence to date that more frequent dosing of immunoglobulin will offer more protection. So the usual 3 to 4 weekly infusion should just be carried on for those on IVIG, or really those on subcutaneous IG should just be continuing every week, or maybe they could be on every fortnight, but whether they make it more frequently to weekly, I think there's no evidence to date that is going to offer more protection. And of course, we know that whilst immunoglobulin replacement therapy provides protection against a range of infections, it does not guarantee immunity against coronavirus. So I think there's also the recommendation that those on IRT and showing poor clinical signs and are seriously ill should be quickly considered as candidates for convalescent plasma. And we feel that for those who are not on IRT, there's no need to start immunoglobulin infusions, okay? Since antibodies targeting COVID-19 is not expected to be contained in the existing preparation. So that, of course, was then in 2020. It could still well be the same going on into 2021. So lastly, I'm just going to touch about the COVID-19 vaccines and in IEI. And I think if you look in general, any vaccines, the approach would be to ask two questions, right? So could the patient be harmed by administration of a live or viral or bacterial vaccine? And will the patient make a sufficient response to the vaccine to justify its use? So that's why, and more recently, in recent times, we are not very recent, but we have been using vaccines as a diagnostic use for IEI. So essentially, what is being said here is that vaccines may be less effective, or it could be harmful in IEI in general. So if you look at the types of vaccines available, so we have the non-viable vaccines and the viable vaccines. And if you know the all the common existing for the childhood immunization, this will be the types of viable vaccines. But as we know from those current COVID-19 vaccines, they are not live vaccines. They are none are live attenuated. So there shouldn't be any issues about the usage of it, right? So it is a matter of whether it is going to be of benefit. So this is a very busy slide, I think, simply because it sums up the different vaccines, both inactivated or subunit or live attenuated in general. So the COVID vaccine 19 would be here. And then looking at the different groups as per IUIS classification, right? So that's why then they would classify each of the vaccines. Either there's no possibility of harm, there's good possible benefit, and administration is recommended, and so on and so forth. Okay, so you wouldn't want something like that could possibility cause harm, and there's no benefit unlikely, so we are not going to recommend the administration. So for those IEI patients post transplant or gene therapy, because I'm just looking at the bigger picture, then they could have the inactivated influenza 6 months after the therapy, and 4 months if there is a community outbreak, and then the recommendation for pneumococcal 3 to 6 months after the transplant or gene therapy, and 12 months for the pneumovax, and for hip hepatitis B meningococcal 6 months, and then DTaP 6 months. And those who are on IRT, the immunoglobulin provides the protection, okay, really. But then there's also recommendations for influenza, human papillomavirus vaccines, and also typhoid, okay, because these are not really the ones that are going to be protected by the IRT. And we always remind patients that there should be also vaccinations for family members. It's essential to protect the patients with a PID. So this statement alone would say that those family members with patients who got PID should be getting the COVID-19 vaccine if there's no contraindication. Okay, so the um, recommendation, and this comes out from the International Patient Organization um, for primary immunodeficiency. So their recommendation is that there is not enough validated data to establish the mid-term to long-term efficacy and tolerability or side effects for the recently approved COVID-19 vaccines in patients with IEI. Now, however, based on the so far that we've gotten from the general population on the tolerability and the efficacy and the side effects, I know there have been a lot of new news coming out from the AstraZeneca, but again, I'm not going to be talking into the details of that. But it is, it should be beneficial, although the immune response, it is not very clear. But it is the simple notion that any vaccine would be better than no vaccination. Okay, so not to forget, they, and of course say the same thing, recommended that the close contact should get vaccinated, and but do consult the each individual PID expert physician before receiving the vaccinations. Okay. So the other things that they mention is patients who do not respond to vaccines by measurable antibody titers, right? Such as patients with antibody deficiency, including patients with profound hypogammaglobulinemia or agammaglobulinemia, should still be considered. So that's what I've already stated earlier for the vaccination, as the vaccines have been shown to activate the cellular immunity via the T lymphocytes, which then may provide a partial protection against COVID-19. So this principle also applies to patients who receive therapy against B lymphocytes, such as rituximab. And just like the general recommendations, patients who already had COVID-19 and recovered are still recommended to get vaccinated. Okay, and the current evidence, what has been stated in many WHO, CDC, that because maybe reinfection is uncommon within 90 days, so we get the COVID-19 vaccine after 90 days, all right? And this also is to avoid co-infection with the influenza virus, okay? Now, just to take another patient group, because obviously we will also come up with a similar MSAI MyPOPI, but it won't be different too much from what has been stated by IPOPI. And here's closer here is the Australasian Society of Clinical Immunology and Allergy. So they are saying that there's no evidence that people with immune system disorders in general, not just IEI, but also allergy and autoimmune condition, are at any greater risk of COVID-19 vaccine allergy. Okay, so I think that's particularly with the Pfizer and Moderna, which is the mRNA vaccine, where there have been cases of anaphylaxis. And people with certain pre-existing medical conditions have been identified as one of the initial priority groups. Okay, so obviously I being one of those, so that's why they are recommending this group to get the vaccination. And just as a reminder, for those who are on the monthly intravenous immunoglobulins, usually you will get the vaccination 2 weeks after the infusion. So this is to avoid confusion about cause of side effects or allergic reactions if they occur in response to the COVID-19 vaccine or the infusion treatment. So there, I think in the last 30 minutes or so, I was talking about IEI and looking at whether and showing that there is a case of severe COVID-19 as a phenocopy of IEI. What are the prevalence worldwide of IEI patients getting COVID-19 infections, and the statements both on the management and also on the use of vaccines in patients with IEI. With that, I thank you very much.
Lecture on both the PID and also COVID-19. I think that Amin has highlighted some interesting and I think very important and useful points. Certainly when you managing those conditions, the decision that you make will change the life of your patient, and also we go on towards the beneficial effects of your management of those patients. Before I introduce the next speaker, I would like to urge anybody that like to ask question to put their question in the chat box during this live session. The next speaker give me a great pleasure to introduce to you Dr. Cheng Yu Kwan, who is our close neighbor and also a neighbor of MSAI. He is actually an allergist and rheumatologist at the Farrer Park Hospital in Singapore. He received his earlier training at the National University of Singapore and also at the Tan Tock Seng Hospital for his specialist training. Later on, he went to be trained at the Mayo Clinic of Rochester. He's currently practice, in a private practice, but he is also, because of his passion for teaching, he teach at the as a visiting professor at the Tan Tock Seng Hospital. At the Yong Lu Lin School of Medicine, National Institute of Singapore. Because of his expertise, he sits on the board of the hospital, as well as the International Body of Rheumatism and also allergy. He's currently the president-elect of the Allergy Clinical Immunology Society of Singapore, and he will be talking about allergies and also COVID-19 vaccination, which I think is a very important topic nowadays. And over to you, Dr. Yu Chong.
Thank you, Prof. Baha, for the kind introduction, and greetings from Singapore. Before I start on my sharing on allergies and COVID-19 vaccination, I would like to thank the organizer for the kind invitation to speak at the 20th Annual Congress of the Malaysian Society of Allergy and Immunology. So this is the objective of my talk. I'm going to provide an update on COVID-19 pandemic and the current available vaccine. I will define and discuss the various types of allergic reactions to drugs and vaccines with a focus on immediate reactions to vaccines. I will discuss about the side effects of a new class of vaccine that's being used, the mRNA vaccine, focusing on anaphylaxis, and briefly talk about the approach to vaccine allergies and anaphylaxis. This is the current situation in the pandemic. This is a dashboard from the WHO. At the current moment, as of 31st of March 2021, we have already about 128 million confirmed infection, and about 2.8 million people have died from the COVID-19 worldwide. Not only has it caused a loss in lives, but also in livelihood. And you can see this very busy chart here and you can see the increase in the unemployment rate, the change in the government budget balance. Almost all government have a negative budget, and all the GDP growth has been negative, perhaps with the exception of China. So COVID-19 has affected not just life, but also livelihood. And how will this pandemic end? Well, in this cartoon, you can see that vaccination is now seen as the main intervention to resuming travel and a new normal. Currently, majority of the world population is still susceptible to infection. And how are we going to slow down this spread of the SARS-CoV-2 such that we do not overwhelm the healthcare system and get enough people to immunize to prevent future major outbreaks? Well, thanks to scientific advances, we now have got 5 current vaccines that is available slightly less than a year after the outbreak. On the left here, you can see the Sinovac vaccine. This is the good old inactivated virus given 2 doses, 2 to 4 weeks apart, approved for more than 18 years old. It is reported that it is 100% efficacious against severe disease, about 50.6% for mild, and about 83.7% for moderate. You have on the second candidate here, which is the Russian vaccine, the Sputnik 5. This is an adenovirus vector vaccine using a virus to introduce the genetic sequence of the spike protein into the patients that receive the vaccine and then stimulate an immune response. A relatively new technology that's also been used in the Ebola outbreak. Again, approved more than 18 years old, 2 doses, 3 weeks apart. The reported efficacy against moderate to severe infection is about 100% and about 91.6% overall, if you include the mild infection. I would just like to point out that efficacy measurement is not the same across all the 5 vaccines, and different trials have got different endpoints. So this is not a head-to-head comparison trial. In addition to the Russian vaccine, we do have the AstraZeneca vaccine, which is also an adenovirus vector vaccine, works in the same way. And we have the J&J vaccine. The J&J vaccine is actually the only one that requires 1 dose. And you can see the reported efficacy here, and it is different amongst the in the different continents, probably reflecting its efficacy to the different strains of COVID-19 that is currently circulating around the world. Of course, in the 3rd and the 4th column, you see the Pfizer-BioNTech and the Moderna, and these are mRNA vaccines being used in human for the first time in human history. These two receive this efficacy for the mild or the symptomatic infection is reported to be 95% for the Pfizer-BioNTech and 94.5% for the Moderna virus. It is probably the highest amongst these currently used vaccine. So in the phase 3 trial, but does this translate into clinical, into real life situation? And I think in the real life setting, and if you look at this article that's been published in NEJM on the 24th of February, coming out from Israel, in this observational study, what they did was that they compared about 500,000 patients that has 500 individuals that has been vaccinated against 500 match individual that has not been vaccinated. And if you can look at the graph here, you look at the documented SARS-CoV-2 infection, you can see this, it starts to split even at 14 days, which is after the first dose. And this after the second dose, you can see that there is a definite difference even in a real life situation. Not only that it is efficacious against documented SARS-CoV-2 infection, it is also effective against symptomatic COVID-19 hospitalization, severe COVID-19 infection, and death due to COVID-19. Unfortunately, we still have a long way to go. As of 31st of March, there's only been about 500 million doses of vaccine given. This is out of a population of 7.8 million of a global population. So there's a long way to go. And unfortunately, the delivery of vaccines is not equitable. And there are many countries that still do not have vaccines. But I think the good news is that we have many candidates that are available. This is as of August 2020. Although there are 5 approved, but the total number of candidates that's being studied is 218, and those that have entered human trials is 24. And in addition to classical platform, which is like the Sinovac vaccine, the whole inactivated virus, there are other protein subunit, which is also being used in the seasonal influenza vaccine. We have the virus-like particle. And this is these are the next generation platform, example of which is the Sputnik 5, the J&J, and the AZ, the AstraZeneca vaccine. And this RNA vaccine that's being used for the very first time. So although there are challenges, but there are many candidates vaccine that hopefully will be made available to the world. After the mRNA vaccine has been introduced, I think we all recall that in December last year, UK being the first country that started using the Pfizer-BioNTech vaccine, there was warning after 2 NHS workers developed a severe anaphylactic reaction to the vaccine. That created some scare. And so the UK drug regulator said anyone with a history of significant allergic reaction to food, medicine, or vaccine should not currently receive the jab. So this will be the topic of interest today that I will speak on later. But I just want to highlight to the audience that these are very, very, very rare events, all right? And if you look at that, for the Pfizer-BioNTech, it is about 11 per million, 11.1 per million injections, per million injection. So how severe is this risk? Well, this is lesser than a chance of us getting into a car crash. The risk of a car crash is about one in about 112, and in an aeroplane is in about 1 in 8,000. So I think it's an important problem, but it is higher than the normal. And if you can look across the table here, Moderna is lesser, it's about 5 per million, whereas for the rest, it's not been reported. And for the inactivated virus, the Sinovac is even very, very low. So even though that the Pfizer-BioNTech seems to have a higher rate of anaphylaxis, it is not an alarming. It is actually less than the chance of us crossing the road and involving in the road traffic accident. And the more common mRNA vaccine adverse effects is being shown. You can see here that about for the Pfizer and Moderna, they are about the same. About 84 to 90% of them receiving such mRNA vaccine will have pain at injection site. I have received 2 doses of the Pfizer vaccine. I had significant pain and swelling, but it's no big deal. It goes away. I had fatigue. I felt like sleeping, the headache. My wife, who had the vaccine as well, had some fever, such swelling at its site. Slightly higher than like a flu vaccine, but these are by and large more common, and these are not actually allergic adverse reaction. Before I dwell into the mRNA vaccines-induced anaphylaxis, let us just take one step back and look at what is an allergic reaction. Well, this little cartoon shows that any adverse drug reaction, being to penicillin, to antibiotics, to allopurinol, to vaccines, all right, there can be two types. There can be a type A, which is predictable, dose-dependent, occurring in majority of us. For example, you take a first-generation antihistamine and you feel sleepy. That's expected. Whereas the type B, or the type 2 kind of reaction, it is unpredictable, it is not dose-dependent, all right? And this is what we call, by drug hypersensitivity, if there is an immunological basis, either IgE or non-IgE, we call this an allergic reaction, all right? But of course, it can be non-immune mediated as well, such as some of the idiosyncratic reaction. And this is nicely defined by Wow way back in close to 20 years ago, where they defined an allergic reaction as an immune-mediated reaction. And it can be, there are different types. Anaphylaxis is just one type. You can also have a type 2, type 3, or even a type 4 reaction. And this cartoon sums up the immune reactor in the different, in these 4 types of hypersensitivity immune reaction. In the type 1, the key antibody is the IgE antibody. In type 2 is IgG, and in type 3 is IgG forming immune complex. And in type 4 is the T cell mediated reaction. So one example of a type 2 would be a penicillin-induced thrombocytopenia, and of course, a macular papillorrhea in the type 4 reaction. So type 1, we all know about this. We saw it in the news, characterized by urticarial angioedema. It progresses and becomes severe, becomes anaphylaxis. Onset is within 30 to 60 minutes, but sometimes you can have delayed up to several hours, like in the situation of a alpha-gal induced reaction. Now, how about antibodies? The type 2 will be antibody-dependent cytotoxicity. This is via antibody-mediated destruction of cells, is what I shared earlier on. For example, due to penicillin. Other more common reaction will be transfusion reaction. In this situation, the IgG or IgM bind to the cell surface antigen, activating complement cell lysis and opsonization. And the key clinical manifestation is usually cytopenia, fever, hypotension, or agitation, with the onset about minutes to hours, usually less than 24 hours. Type 3 is an immune complex, or serum, classically called the serum sickness, with fever, chills, arthritis. You can see here these patients have got urticarial vasculitis, certain rare manifestations such as aseptic meningitis and serositis. Onset is about few days to 2 weeks. And finally, the type 4 reaction, which we as allergists and many of us, either primary physicians, sees a lot of macular papillary rash after, say, amoxicillin. And this tends to occur either a few hours to days, depending on whether the patient has been sensitized. This is the mildest form of T cell mediated. There can be severe type 4 reaction. Of course, we all know about Stevens-Johnson syndrome, which can, if the drug is not removed, it can progress to TEN. And of course, you can also have a drug reaction with eosinophilia and systemic symptoms, or also known as drug-induced hypersensitivity syndrome. In this potentially life-threatening reaction, which is basically T cell mediated, patients develop rash, eosinophilia, hepatitis, lymphadenopathy, and fever. And a classical example would be an allopurinol-induced reaction, especially in the Han Chinese associated with HLA-5801. So I show you some pictures here. From the left, the not so life-threatening macular papular target lesions Steven Johnson, if it's less than 10% of blistering, and 10 to 30, we call it overlap, and more than 30% of blistering, we call it TEN. Now, drug reaction or vaccine reaction causing type 2, type 3, type 4 reaction is even more rare compared to anaphylaxis. If you recall that the anaphylaxis rate to the Pfizer-BioNTech is about 11 per million injection and 5 per million for the Moderna vaccine. But if you talk about the non-type 1 reaction, we do not know the exact incidence. There hasn't been any report, and probably it's actually even more rare. And in addition to the cutaneous reaction and those signs that I've shown you, do note that there are other type of vaccine immune-mediated reaction that's been reported. And if I will just like to highlight this autoimmune inflammatory, where patients can develop Guillain-Barré, that's something that we are aware of, or ritis, or thrombocytopenia, or vasculitis. So what is this? Why does it cause it? It is believed to be self-reactive antibodies, and Guillain-Barré is one of those that is being reported, and the numbers are there, and that's the vaccine that is referenced below if you are interested to read more about this. And different population probably have a different rate of reaction. I'd like to just point to you two very useful articles. The ICON, which brings together three allergy body, the WOW, the AACI, the AAI, and the IACI. And this paper defined by what we mean by allergic reaction to vaccine, and how do we approach. And the second paper is just been published. This WOW anaphylaxis guidance is a very useful paper. I would encourage you to read it. In the ICON 2016 publication, they classify local injection site reactions such as swelling, redness, or soreness, and constitution symptoms, especially fever, very common, as an immediate non-allergic reaction. So remember, I showed the chart of the mRNA vaccine with about 80–90%. These are non-allergic reaction. If you have this, please carry on and continue with the second dose. Then they define what is immediate allergic reaction, which can be limited, whether is it bronchoconstriction, rhinoconjunctivitis, GI cramps, generalized urticarial angioedema. And I just want to highlight that they define this immediate as onset within minutes to 4 hours. And of course, if you have a life-threatening reaction, then we call it anaphylaxis. But what's life-threatening reaction? Life-threatening may mean different things to different people. I particularly like this WOW 2020 anaphylaxis. It's very operational. It let clinician, it gives clear guidance to clinician. So the first criteria is when you have an acute onset of an illness, minutes to several hours with involvement of the skin, be it hives, flushing, itch, swollen lips, tongue, uvula, plus at least one of the following, whether is it airway, whether is it circulation, or whether is it GI. The second criteria is applied to individual who already has a known or highly probable allergen that he or she is allergic to. And you can also diagnose anaphylaxis even in the absence of such typical skin involvement. If you find that in the adults, they have a systolic BP of less than 90 or greater than 30% decrease from that person's baseline. And in infants and children, a low systolic BP, which is age-specific, or greater than 30% decrease in the usual systolic BP. Or you have airway, i.e. bronchospasm or laryngoedema. So this is actually a very useful definition, rather than just saying that a life-threatening reaction. But life is never simple. And I remembered when I had my vaccination, a nurse next door was having hers, and then I heard the RMO having some commotion and was about to give this young lady who felt faint an EpiPen. So I think this is important, and I will just spend some time going through and perhaps help to give some key pointers how we can differentiate between the vasovagal episode and anaphylaxis. Number one, the onset. Usually for vasovagal episode, it is very immediate, sometimes even before the needle reaches the patient, within minutes, all right? And if it's anaphylaxis, it's usually within 15 minutes. It must be at least after the vaccine has been vaccinated. Look at the respiratory sign. Normally in vasovagal, breathing may be shallow but not labeled. But in anaphylaxis, there will be wheezing, there will be hoarseness, there will be stridor. You may even see swelling of the lip, the tongue, the throat, the uvula, and the larynx. How about cardiovascular? In vasovagal, one tends to be bradycardic, whereas in anaphylaxis, they tend to be tachycardic. Usually, there's an absence of carotid pulse in anaphylaxis, but in vasovagal, there's actually a strong carotid pulse, and hypotension is usually very transient. Anybody with vasovagal, just lie them flat. Within minutes, they will wake up. But this is very different in anaphylaxis. If you don't treat, the BP can remain low. And look at the skin. In vasovagal, it's cool and clammy, whereas on the other hand, urticarial angioedema. And one very key important point that I'll look for is a generalized skin erythema and redness. And in anaphylaxis, they tend to have abdominal cramps, because of the action of the on the histamine receptors, which can actually cause abdominal muscle contraction. And the the intestinal constriction. Neurological symptoms in vasovagal, they feel faint, whereas anaphylaxis, there's this sense of anxiety, the sense of impending doom. And many a times they will say, oh, my head is very itchy. The itch is unbearable. And these features are actually modified from the Brighton collaboration case definition criteria for anaphylaxis, which is used in reporting of vaccine-associated anaphylaxis. Of course, if you are unsure, you can measure the tryptase and the histamine level after anaphylaxis. This graph here shows what happened to the histamine and tryptase level after a venom challenge. Typically, histamine rise faster within 5 minutes, but within 30 to 60 minutes, the level will drop. All right, and it's difficult to measure. So if you're unsure and if you want to measure, tryptase should be measured. And it usually peaks at 1 hour. It stays in the serum for about 6+ hours, but it's best to take the blood an hour after the event and less than 3 hours. So there's between 1 to 3 hours. Normal level is 10 nanogram per ml, have very good positive predictive value of 92.5, which means that if it's positive, in the lack of other differential, this is most likely a anaphylaxis. However, negative predictive value is not as good. It's only about 50%, which means to say that even if the tryptase level is normal, it does not exclude anaphylaxis. So the clinical correlation is actually still very, very important. And all of us would know that the treatment of choice in adrenaline is, the treatment of choice in anaphylaxis is adrenaline, IM 0.3 milligrams to the mid-lateral thigh. Maximum adult dose is 0.5 milligrams. If it's a peds patient, 0.01 milligrams per kg. You can repeat every 5 to 15 minutes. But if you require 2 to 3 doses and the patient is still not responding, quickly set IV drip. You can give your steroids, your antihistamine, your fluids. I think, this is, but key point here is adrenaline and timely administer this in a timely manner so that you arrest the progression of an allergic response, which usually start in the skin before they involve the airway and of course the cardiovascular. organs, leading to end organ damage. So I've mentioned that the Pfizer Moderna, the Pfizer anaphylaxis is about 11.1, 11 in a million. It does 5 in a million. If you compare that to, but this is not just to the mRNA vaccine. If you compare the estimated rate of anaphylaxis in for the other vaccines ranges from 1 per 100,000 to 1 per million. So the flu is around 1 per million doses. And these rates are mainly from pediatric study. And true rates of allergic reaction is unknown. I've never seen one myself, but I'm not a pediatric allergist, so I may not be giving that many vaccines. So what in the vaccine component causes this? Well, so this lists down, these are the possible causes, components that can cause an anaphylactic reaction. So the vaccine consists of not just active immunizing antigen and conjugating agents. So you can see here toxide, live attenuated virus. In the Pfizer-BioNTech is the mRNA. We also have culture medium, for example, eggs, yeast. All right, you can have antibiotics, preservative, stabilizer, and particularly gelatin has been a culprit. You can also see here polysorbate 8020, adjuvant, and of course latex, either due to the contamination in natural latex or the protein that's found inside that. So these are the components of the vaccine, and any of these vaccines can actually cause a reaction. Now, what in the mRNA vaccine, what's been implicated is perhaps the polyethylene glycol, PEG for short. What is PEG? PEG is actually a hydrophilic polymer frequently used as an excipient in everyday product, including medicine, cosmetic, or food. It is increasingly being recognized, but the incidence is not very high, and there is a possibility of cross-reactivity with polysorbate 80 due to a shared chemical moiety. And this is actually the moiety that we talk about in the PEG, and you can see here that it's also found in the polysorbate. If you look at the number behind the PEG, it's actually how many repeats and what is the molecular weight. And you can see this is found in both the Pfizer-BioNTech and the Moderna. But such excipient is very common. You can see here influenza, Hep A, hepatitis B, Japanese encephalitis vaccine, pneumococcal or Prevnar. All these contains polysorbate 80, and PEG is found only in the Moderna and Pfizer, whereas I mentioned AstraZeneca and J&J, it contains polysorbate 80. But the levels are actually very low. It's only 22 micrograms. So I think it's not proven beyond doubt that it is due to the PEG. So this Pfizer-BioNTech and Moderna is approved under the FDA EUA guidance, all right? And they state here, do not administer to individuals with a known history of severe allergic reaction, i.e. anaphylaxis, as defined by WOW, to any component of the COVID-19 vaccine. But if you have got allergy, anaphylaxis to oral medication, including the oral equivalent of an injectable medication, please proceed. If you have got history of food anaphylaxis, aeroallergens, pets, cats, dog, or insect venom anaphylaxis, environmental, latex, contact dermatitis, these are not contraindication. You can proceed. And in the US, they suggest that you're monitored for 15 minutes. So in the yellow box, how about someone with any immediate allergic reaction to other vaccines or injectable therapy? You can still proceed, but you monitor them for 30 minutes, and they do suggest that you can perhaps profile their risk by asking some question and assessing whether or not their previous reaction to the vaccine and injectable contains similar excipient that is found in the mRNA vaccine. Of course, this is a given. If you have a severe allergic reaction, i.e. anaphylaxis, after a previous dose or to the component of the vaccine, don't give. And I would just like to highlight that after the first dose, if you have an immediate allergic reaction, even if you do not have anaphylaxis, CDC says hold, get it evaluated before giving the second dose. But different country has different. So we have got a 25th January 2021 MOH and a 12th March also from MOH, a guidance on how you should use, because this is also authorized under emergency use in Singapore. So Singapore is very strict, we are very cautious, and we are very different from the CDC in the sense that MOH recommend that anybody with anaphylaxis to any drug, vaccine, food, insect stings, or unknown trigger, or history of having prescribed an EpiPen, an allergic reaction to Moderna or any of its components. And even interestingly, you see that a severe cutaneous drug reaction, although this is really being very, very cautious. As I said, the incidence of this is really, really, really very, very low. But this is similar to what CDC has said. If you have allergic reaction to other vaccines, you can refer to allergists for further review on suitability. This is the yellow box here that I've mentioned. So what's the clinical approach? Well, I think it's not difficult. You can actually see here, this paper comes from the WOW publication 2016, positive history of reaction after vaccine administration. If it's a non-immediate reaction, usually no allergy workup. If it's a contact dermatitis or nodules, you can consider a patch test, but most times we can still just proceed with the vaccination. If it's an immediate, consider skin testing or in vitro IgE testing if the kit is available. You want to test to the vaccine or its component. If it's positive, and if additional doses is given, you can give it in a graded dose. If it's negative, just give per normal. On the other hand, some of the patients may give you a positive history of an immediate allergic to some of the excipients, for example, gelatin, latex, or yeast. I've shared with you the components of the vaccine earlier. The pathway is the same. You choose based on the history what you want to test, and depending on the test results, you proceed. So this is applicable to the mRNA vaccine. So these are the questions that you should ask if they tell you that, I have a previous allergic reaction to prior vaccine or injectable. So these 4 questions are as follow. Do you have a history of severe allergic reaction to an injectable medication, IV, IM, or subcutaneous? Do you have a history of a severe allergic reaction to prior vaccine? Do you have a history of a severe reaction to another allergen, food, venom, or latex? And do you have a history of immediate, less than 4 hours, or severe allergic reaction to PEG, polysorbate, or the polyoxyl 35 castor oil containing injectable or vaccine? If answer to all 4 is no, they are low risk, all right, then you can proceed 15 minutes. And if it's yes, all right, 1, 2, 3, all right, it's medium risk, you can still proceed with the 13 minutes after you take a little bit of history. These are people with history of potential anaphylaxis to a vaccine or injectable medication without PEG or polysorbate. So you need to take a little bit of history and assess and do a risk assessment, as what I've shared earlier. Of course, this high-risk individual giving a history of potential anaphylaxis to an injectable medication or vaccine containing PEG and PEG derivative, or history of potential anaphylaxis to oral PEG, which is used in the bowel prep or colonoscopy, then you want to consider the clinical phenotyping and the expanded skin testing before you proceed to give the mRNA vaccine. Now, this is the diagnostic test that has been suggested, either skin prick or intradermal. What you would use would obviously be directed by the clinical history. If skin testing is positive, stop, and then then these patients are ineligible for PEG or polysorbate containing vaccines. All right. If not, if the skin tests are all negative, you can proceed on. And this is a little table again from this very nice publication from Jackie on 31st December 2020, telling you where you can find this PEG 3350, polysorbate 20, polysorbate 80, for example, in Refresh Eye Drop, in Prevnar, in methylprednisolone, and in Miralax, which is the bowel prep. So with that, I would like to conclude that vaccination is definitely the way out of the pandemic, that no vaccine is 100% safe. mRNA vaccines appear to have higher rates of anaphylaxis, but remember the incidence is still really, really low, less than the chance of a plane crash. And the benefit certainly outweighs the risks. Although the local reaction seems to be higher, but the efficacy also seems to be higher as well. Bear in mind your own national guidelines. So you can see, as I've shared, that the Singapore guidelines is very cautious. It is different from the CDC guideline, but we have to obey your country's guideline, as many of these are authorized under the emergency use. I hope you realize that it is important to recognize anaphylaxis. Do remember the operational definition from the WOW 2020 paper, and do remember that early recognition and treatment is very, very important. And I've also shared with you the role of an allergist in evaluating vaccines allergy, and the very useful publication coming out from Jackie, 31st December. You can refer to that if you need to evaluate your patients with possible PEG or a polysorbate allergy before mRNA vaccination. With that, I thank you again for the kind honor and the invitation, and welcome any questions. Thank you, everyone.
Professor Dr. Cheng Yu Kwan. Certainly, I would say that I agree with you. All those points are very interesting with regard to vaccination. Thank you to all the speakers for their very, very important topics, and also what they have highlighted. We don't have much time left, but there are so many participants who ask on vaccination, and there's a common thread with all those speakers about vaccination. They touch on some aspect of vaccination. So what I'd like to do here is, before we end the session, is I would like to have an open forum among the three speakers, and to get their insights on vaccination. To start off with, there's a question about vaccine. Which vaccine is the most suitable for or recommended for people or patients with those individuals who has history of severe allergy? In your opinion, what do you think is the most what's the vaccine that's recommended or suitable for those who have history of severe allergy? Maybe I start off with our first speaker, Professor Dr. Ruby Pavankar.
Thank you, Professor Baha. That's a very important question. But the most important thing is, how do we define severe allergy? Are we talking about severe asthma? Are we talking about food allergies? Are we talking about anaphylaxis to just foods, or anaphylaxis to drugs and vaccines? Depending on that, the decision to have vaccination itself will change. That's number one. Because if it's to, as Professor Chang just mentioned, it depends on whether the particular vaccine has a recipient, if there's a history, as in the ICON paper, a history of anaphylaxis to vaccines, one would actually investigate them. Then depending on the country that you are in, there is a risk stratification is different, and also the availability of whether skin testing is available or not, that will make it different. Now, if you're telling me which vaccine is better, or which vaccine, I think nobody can answer this question, because at this stage, there is no head-to-head study comparing the different vaccines to see which vaccine has more side effects over the other. There is no head-to-head study. So it's a difficult question to answer. But as already mentioned in the last talk, that the general guidelines by CDC or FDA, which is a little bit less stricter than that of Singapore, would allow, and that's the same thing we follow in Japan, would allow actually vaccination, provided they do not have a history of anaphylaxis to a particular vaccine that has the SCPN that is present in like polysorbate or PEG.
Thank you, Prof. Ruby. Dr. Amir?
Yeah, I would echo the same answer approach really to Prof. Ruby. And I think if you look at the approach here, and I did that risk stratification based on these two papers that the last speaker had already mentioned. Prof. Chang, thank you for that. I mean, the WAO is, I think you need to read that, and together with the one that's come up from the American Academy. So we've used that and to look into the risk stratification, and what has come up from the infographics for those eligible for the vaccination that has come up from the Ministry of Health has highlighted the fact that if you have anaphylaxis, you should be referred for further assessment, right? And if we look at it, then we talk about anaphylaxis mainly as the screening question towards any injectable drugs. I also put in the suppository drugs as well and previous vaccines. And of course, has already been highlighted, the polyethylene glycol, the PEG, in the mRNA is the one that has been brought up. It's the excipient. It's not the active ingredient, but it's the excipient. And of course, we have, if you had past reactions to other vaccines, and which has the polysorbate, which could even be in the simple influenza vaccine, then we just need to be sure that they do not go into the higher risk. But as it is, the capacity here in Malaysia to do the skin prick test is not going to be that readily available. So I have to look into that as well. We have to look into that properly. And we are looking into other means like a basophil activation test as we speak to kind of assess those who are particularly going to be having problems with the PEG, both the 3000 and 2000 Daltons. So that's something in the pipeline. But otherwise, we have to refer to the severity of the allergy in the first place. So there are risk stratification here in Malaysia. The recommendation from that to the Ministry of Health has been made, and so we have to take it on an individual basis.
Professor Yu Kwan.
Thank you, Chairperson. Yeah, so I think the guidelines are there. And personally, I mean, this is speaking on personal basis. I don't think that we have to overplay the issue of anaphylaxis. As I said, it's really very, very uncommon. It is less than your chance of you having an airplane crash. So that's so rare. So what's the experience of anaphylaxis in Singapore with the mRNA vaccine? I see that question in the chat box. I would say that the numbers are not high. I only know about maybe about four cases so far, but our numbers are not high out of about 1 million that has been injected, and predominantly these are the Pfizer BioNTech vaccine. So even I also know of many friends and doctors that have hid their anaphylaxis and they have gone. One of my colleagues was sitting next to me, and I said, "Oops." Then she said, "Shh," and there was actually no problem. So it's actually very rare, and PEG allergy is actually very rare. And if you attended the Quad AI meeting, there are people in the US who had actually first dose and then with some reaction, and they go on to get the second dose without any issue at all. So I do see that there are questions about penicillin allergy and tramadol. I think these are not an issue, even if they had anaphylaxis. But unfortunately, in Singapore, anybody with anaphylaxis are excluded. You have to follow your guideline from the government because this is approved under emergency use. I do see a question of how soon you can give your flu vaccine. I suppose that is actually in Singapore, our guideline is 2 weeks after the flu vaccine. So the duration should be at least 2 weeks. I don't think that this is based on science, but this is just empirical expert weakness. And I see there's someone with the BP shooting up. I think it's just anxiety, like the nurse who had this so-called vasovagal and nearly diagnosed to have. I even had one that was screaming so loudly even before the needle go in. So I think this is what I have, and I believe I've answered all the question. Yeah, over back to you, Prof. Baha.
Yeah, I totally agree with you. Even though anaphylaxis is being mentioned so often and whatnot, we tend to see more people suffering from vasovagal fainting after the vaccination or even before the vaccination, because they're so scared and probably phobia about the injection, or even probably because of the vaccination. We have to end. Time is really coming up very soon for us to end. But before we end, maybe I'll give you 1 minute each to talk about, to mention about the vaccination. So many people are interested to know how long is the protective effect of the vaccination, and when can we travel when we have been vaccinated? Prof. Ruby, 1 minute.
Can you repeat the question?
How long is the protective effect of the vaccine, and when can we really travel soon?
Okay. According to the World Health Organization, they are saying approximately 8 to 10 months is the protective effect that has come out from the data from the different studies. But still, studies are further evaluating and seeing whether it's 8 to 10 months or it's even further. The other important thing is right now, there is, like actually already all the speakers mentioned, that there is this vaccine hesitancy, partly because there are groups that are anti-vaccine groups. And second of all is because this pandemic has resulted in the vaccine development in such a short time that people, every adverse reaction gets reported. So it gets highlighted much more than actually what is seen in other vaccines, which are known to cause anaphylaxis or other side effects. So the most important message, as me in person, as well as Apache, is we are trying to say vaccinate yourself. This vaccination is absolutely important to protect yourself and to protect people around you. And the only way out of this pandemic is vaccination for the majority of the global population. And this is what even the World Health Organization is struggling, because despite the COVAX, they still have shortage of vaccines to be able to provide to the rest of the world. For example, Africa, less than 1% of the population is actually vaccinated. So my recommendation is vaccinate. You need to be careful. If there are things, consult the allergist, but vaccinate. And whichever vaccine you can get, that's crucial.
Dr. Amin?
Yeah, if I were to answer the same question, it's already been answered. So, I mean, that's the key thing, right? I mean, and here the experience in Malaysia, as well, right? When we look at the numbers that has been registered or have registered themselves, it's probably, last count I remember, is 33.6% have registered to receive willingly and has said yes to our app that we have to get the vaccination. So what happened to the others, right? And when you look at that app, there are more than 21 million have been registered. And that would be the roughly about that 70-80% of the adults that are in Malaysia. Now, 70% are adults. Less than 18 years old are 30%. So if we want to look at the herd immunity, so which is at 21 million, we only got just about 8 million only as agreed. So this is the issue has already been highlighted, the vaccine hesitancy, and we got to get around that. We have to educate more, and even more, and reassure the public that we need to vaccinate to get out of this pandemic, right? There's no two ways about it. And whatever has been highlighted about the side effects and rightly pointed out by Prof. Ruby is that we are seeing this real time. All the vaccination has been rolled out. We see all the side effects in our lifetime now. Whereas in the past for the other vaccines, we just quietly, we don't even know that it exists until we start looking. The rare cases, oh, this is a very rare side effect of this vaccine, which will now be stated, let's say the AstraZeneca, the blood clots, where there's a causal link now, as already mentioned by the European Medicine Agency. But that is only because we are seeing it real time. as we learn more and more about this disease. This is a very fluid, very dynamic situation. So we have to take it as it is now. And as it is now, I say, please, everybody, all 21 million Malaysians, please get yourself vaccinated.
Prof. Yukon, 30 seconds before we end.
Okay, so I think there's one question from Mr. Wong Kim Fat, whether adenovirus vector vaccine is considered a live vaccine. It is not a live vaccine, all right, but I think if you look at the AZ vaccine is actually from it has been attenuated. But if you ask me, I would prefer mRNA vaccine, which will be safer because there's no way that the virus can cause any issue. Coming to the vaccination, actually mRNA vaccine technology is not new. It is actually 20 years in the making. This started during SARS, and therefore once they have the genetic sequence, they were able to come up with this. And I think the trials are actually robust because of the pandemic. You're able to get the trials being carried out and have such quick results. And if you were to look at the real life study coming up from Israel, where they have vaccinated now close to 80% of their population, they see an immediate relief of the stress on the healthcare system, as I've shared earlier in my talk. I think when can travel resume? It will be really between a negotiation between the different government. As it is now, Singapore really have got a green lane with New Zealand, Australia, Vietnam, and Taiwan. So I think this is more a political and a government-to-government interaction rather than because no vaccine will be completely 100% efficacious, and we are still not too sure about sterilizing immunity. So that I think is the key point. Perhaps in a year's time, we would have more data. That's all for me.
To all eminent speakers, thank you so much for being with us. Thank you for sharing your expertise, your experience. I'm sure it makes a lot of, important understand. It makes a lot of sense and it makes a lot of important contributions towards understanding what is happening now with COVID-19, what is happening with our allergic patients and whatnot. I'm so sorry that we don't have more time to really go into details about all your topics and whatnot. But I would like to, say that it has been very, very, I have really enjoyed all those, your what have you shared with us. And I would like also to thank those who had actually, contributes towards the success of our Congress. Elix, one good example, who has been very diligent, who has been, coordinating with all those speakers to ensure the success of our Congress. With that, ladies and gentlemen, thank you so much. And I hope we can, look forward towards the Apache Allergy Week during the Apache meeting. And so I would like to, for us to meet again soon. Certainly for next year meeting, we have another 2022 MSAI Congress. Thank you so much, ladies and gentlemen. Take care and stay safe.
Bye.